Good morning, everyone. Welcome to Dashboard Dissections, Cosmetic Surgery Edition. I already forgot what episode we're on. I want to say this is episode 5, maybe it's 6. Sorry. I'm a work in progress. We'll get better at this. But today we are headed to Tullahoma, our surgery center down south, is what I like to call it. The people here are great. The people that work there are wonderful, and I always joke that when I come home from my Tullahoma days that I got a little bit of southern twang, a little bit of that deep south. So anyway, if I record anything later today, you might hear a little bit of that. It's super fun. But we have 3 cases today, 3 breast cases, so we're going to go bam, bam, bam. BAM is what we call a breast augmentation mastopexy. We just shorten it to BAM. So on days like this, I like to go bam, bam, bam. But each one of them is a little bit different. So the first one is just a primary breast augmentation. The second 2 are both technically implant exchanges. One patient has saline and wanted to switch to silicone. She likes the size, but they sort of fall to the side from the weight. And overall, saline, we'll get into it in a minute, but saline it was a great option back in the day, but now that the silicone has been tested much better and the safety and efficacy of it is proven, with studies up to 18 years or 19 years was the longest one, now silicone is a much better option in my opinion. Everyone is entitled to their own opinion, of course. By primary breast augmentation, I mean that the patient has not had surgery on their breasts yet, as far as an implant or anything like that. So it is their first primary surgery. Secondary surgery is more revision, so that's what the next 2 are technically. They're technically revisions. The second patient, like I said, had saline implants, likes the size, but just overall doesn't like the weight or the way that they fall to the side. So we're going to be doing an implant exchange with something similar in size. And then a capsulorrhaphy, which I do quite a bit of actually, but all that means, it's kind of a fancy word that's spelled a little bit like diarrhea. There's a lot of R's and H's and stuff, but all it means is augmenting, changing the capsule so that the shape for the breast implant is different. And the way I usually describe that to people is like a pillowcase. The pillow analogy that I use is basically with a breast implant with time, what's going to happen is that the implant is going to fall down and out just because gravity does what she does. And she will no matter what we do. But that sort of stretches out the pillowcase, and so you end up with a small decorative pillow in a king-size pillowcase. And obviously, if you think about that, like the pillow can move in a bunch of different places, it can go where you don't want it to, and then you don't get the decorative part of the pillow anymore, meaning you don't get the pillow to sit in the chest where you want it to be, on the chest where you want it to be. And so I just sew that pillowcase around to hold the pillow where it's supposed to be. And I do that with a suture that dissolves, and that's usually step number 1 to fix placement of the implant. So that suturing on the inside of the capsule where the implant lives is called capsulorrhaphy. And like I said, what that does is it causes the tissue to scar down, and ideally it creates a smaller pocket for the implant to sit in so that it stays in the prime location better. And so that's what we'll be doing on our second case. And the most common place that I do that is on the sides. And on the bottom, because obviously you usually don't have a problem with the implant being too high and in the middle. That's not an issue. Now, that's not to say it can't be, because it can. And mainly that problem is if you go too large with the implant, it can go up too high, and that can be problematic for people that want a very natural look. And sometimes if the dissection goes too far to the middle, medially, you can actually create what's called synmastia. Synmastia is a really, really hard problem to fix because there's not a lot of tissue. Basically, when you create synmastia, you dissect all the way across the chest and you create one pocket. You basically create a uniboob. And it's a really hard problem to fix because truly in the midline, there's really skin, fat, and sternum. And that's about it. And when you create that space closing that back down is very, very difficult because there's not a lot of tissue to work with. So it usually requires more reconstructive surgery where you have to flap tissue down in order to get that to scar back in the midline. Now sometimes you can do a suture and that will hold. A lot of times it will not. And then if you have any concern about it after a breast augmentation, you can try to put a little bit of pressure in between the breasts to help that tissue scar down. Random thought about this, I did actually have a really interesting case of a patient who had pectus excavatum, which simply means that their sternum didn't form correctly, their chest didn't form correctly, and it causes this caved in version of a sternum. And that patient had gotten breast implants to help mask that abnormal sternum that she had. She had gotten them about, I want to say it was 8 or 9 years prior to her seeing me. And so they had started to actually fall inward. The breast implant started to fall inward because gravity was pushing them that way because of the caved in version of her sternum. So that case is coming up next month. I think she's scheduled next month. Yeah. So I'll keep you posted on how that one goes, but that's going to be really interesting. But all that to say, capsulorrhaphy is a great tool, and the problem with it is the stitch that I use dissolves. And if you've ever consulted with me, you've heard me say I don't like permanent things or anything really near a breast implant, because one of the worst things that can happen is you know what I mean. One of the worst things that can happen is an infection of the pocket around the implant, because that requires the implant to come out and for everything to heal, infection to clear, and that usually takes a few months of you not having one implant, and then we can replace it later. But as you can imagine, as a woman, going around with one implant and not having the other can be very distressing, especially for a couple of months. So that's why I don't like permanent things near the implant, because that risk of infection goes up. So because the stitch that I use dissolves, it dissolves in months. So usually anywhere from 6 to 8 months that stitch will dissolve. And the goal is for it to create scar tissue that will stay present long term in the place of that suture. But the results aren't forever. That's the problem with breast surgery, because like I said, gravity, she's cruel, she's a bee. I say it all the time, but she keeps me in the business. So she's going to do what she does, and adding weight to the breast is going to add weight that gravity can act upon. So things are going to move south, they are going to move east-west. They're not going to stay right where we want them to as much as I wish they would. So if we have one of those capsulorrhaphy procedures fail, then the next step is to do something similar, and that's a capsulorrhaphy with a permanent suture. So something that does not dissolve, something that stays forever, is the next step. And the reason that I do things that way is because, like I said earlier, I don't like permanent things near a permanent implant, because inflammation and infection are bound to come about with that, and that risk just goes up. And with something like this, you really want to avoid that if at all possible. So that's step number 2, is to do the same surgery but with a permanent stitch that will never dissolve. Now what can happen with this is the stitch can break, and I've seen that happen. But again, your tissue is going to stretch out, so that doesn't necessarily mean the stitch broke. It just means that time did what she did and gravity did what she did. So that's the other hard thing, is even that isn't permanent, despite being a permanent. And the last step for me is a mesh. Now, a lot of the meshes that are used around breast implants are dissolving meshes. Again, because the idea of having something permanent near the implant is not a good one. So even the meshes that are on the market specifically for breast implants, breast implant placement and support, those internal bras, even those dissolve. So in my humble opinion, I feel that I can do with a stitch done correctly what a mesh can do, especially when a mesh dissolves. And usually those meshes, now there's a ton of different ones on the market. So the ones that I know of usually dissolve in anywhere from 3 to 6 months. So they're less permanent than my stitch. And the reason that I wait so long to use one of those meshes is because then, after a mesh, the next surgery is a nightmare because of the inflammatory process that it creates. And if it's a permanent mesh, it's even worse, right? The inflammatory process is insane with a foreign body like that. And so I never plan for multiple surgeries, and that's not true. I try not to expect having to do multiple surgeries without telling my patients that up front, but I also am trying to plan for your future when I'm giving you a surgical plan. So for me, if I had a breast implant that I didn't like the location of, the first step I would want is a capsulorrhaphy. And I would want to avoid a mesh if at all possible with all the information that I know. So that's the reason that I do that for my patients, is because that's what I would want. Now, I love breast surgery, and I love difficult breast surgeries that are new and challenging, like this pectus excavatum. I'm so excited to do that case. I cannot wait to see inside that and figure that out and figure out that puzzle piece and make her look fantastic again. Not that she doesn't look fantastic, but make her breasts hide that pectus excavatum better and not cave in like her sternum does. And so I love those challenges. But if I can avoid them, especially in something like a mesh where we have other techniques and other options that I feel are safer and better technically for a next revision surgery, God forbid we need it, that's the reason I do what I do. So I have that twice, actually, an implant exchange with capsulorrhaphy, and those are our last 2 cases for the day. There are also some consults in there in between, and it's going to be a good day. Something that I say in consults with people that I feel surprises them is that someone who gets a breast surgery in their 20s or their 30s, on average, has 4 breast surgeries in their life. On average. So there are some people who get one set, love them, go to the grave with them. Fantastic. With the new silicone, you can do that. With the saline, usually there are more replacements required. So I expect that number to go down with the improved technology of silicone. The problem with saline is they're single encapsulated. The capsule is silicone. The silicone implants are dual encapsulated with medical grade silicone. So they're more difficult to rupture. The saline also, because you fill it up, it can also leak. So the way I describe that mechanism is sort of like a child's floaty, like one of those yellow arm floaties from the pool. So similar to that floaty, it's like, you know, when you blow it up with air, and then it's that plastic piece that you have to put the top on and then push it in. It's a very similar mechanism for the saline implant. So if you think about it, it's an empty implant. It's a silicone shell that we put into the body, and there's a tube that comes out with a cap that basically doesn't allow air in or saline out. And then I inject the saline, sterile saline from my sterile field, into the implant. And then when I'm finished putting the saline into the implant to the size that you want, then I pull that tube out and the closure flaps down, and it's this little plastic piece with, like, it's similar to plumbing, like an innie and an outie, like a little hole, and it just bloop pops in there and closes. And that is supposed to hold that saline. And the teaching is to avoid rippling, that you're supposed to overfill the saline by at least 30 cc's, which is about an ounce. So that little plastic piece that I can't see because it's in your body, I obviously go in and feel, although some people say you shouldn't do that because that can introduce infection. So there's differences, there's nuances, there's different teachings. But you reach in to make sure that it's closed, that little nozzle is popped in there, you know. But that little thing is supposed to hold 300 plus cc's of fluid with movement, with healing, with all that. I mean, that is why saline implants leak over time. And given that it's a single encapsulation with medical grade silicone, over a long period of time, that could fail and it could leak slowly from that. So the other thing about saline is that it's extremely heavy. The weight of a saline implant is almost double, depending on the cc amount, is almost double the weight of the silicone implant of the same size. Now, let that sink in for a minute. If you have half a pound, which would be a giant implant, by the way, if you have half a pound of silicone on one side, and you want the same size with saline, that's an entire pound. Now, I know that doesn't sound like a lot, but think about how much we hunch over. Think about how much pressure that extra 2 pounds is going to put on your back, that on your skin, on your tissue. Saline implants will thin out your natural tissue from weight alone. It's crazy. So again, that thinned out tissue makes your next surgery harder. It makes it more likely that no matter what implant you get, that you're going to feel and see that implant. That rippling that you can see with saline, that's from your natural tissue thinning out and being able to see the edges, the capsule of that saline implant. And that problem, similar to synmastia, is really, really difficult, if not impossible to fix. And the fix is what we call a trapdoor. And that usually just creates a new location where you can see rippling and feel the implant more. So it's a hard problem to fix. But again, that's something that your surgeon should talk to you up front about, what an implant exchange will fix, what we can fix, what will not get better. Those are the questions that you want to be asking. What is going to improve with this implant exchange, with this different type of implant? What is going to stay the same? Saline also doesn't have as good of a warranty. The warranty is really only for a rupture, whereas with silicone, the warranty is for a rupture, a capsular contracture, mainly. And those are the two big problems that require a surgical treatment. If you don't like the size, I'm sorry, but that's not covered by your warranty, things like that. So a capsular contracture and a rupture are covered by the silicone. A capsular contracture rate is lower with the gummy bear implant. Now lower by like 0.02 to 0.05% difference, but still lower is lower, okay? And that is probably the most common surgical issue with a breast implant, is a capsular contracture. Now, what that is because we put a foreign object into your body walls it off. It will do that with everything. A pacemaker, a hip replacement, a breast implant, anything. And your body creates this pocket, this capsule, so your immune system doesn't continue to attack. Because your immune system is built to stop invaders, to stop problems, bacteria, viruses, all the things. So it creates this pocket, which is called the capsule. And for reasons unknown, we believe it's a hyperinflammatory response, but that can be caused by a multitude of different things. Infection, a blocked duct, rheumatoid arthritis, what have you. Any kind of hyperinflammatory state can cause this. And it basically means that the capsule that should be thin, almost like a Ziploc bag, should be thin like that, mobile, not firm, not hard. It gets firm and hard, and you can see and feel that from the outside. Usually means that the implant sits up higher, it feels firm to the touch, it doesn't look as natural, it just looks like that capsule is squeezing the implant and it's just right there. It can cause pain too, and that's usually what brings people in. The pain is usually what brings people into the office, and the treatment is to surgically remove the implant, evaluate the capsule visually and on touch. If it looks or feels abnormal, the treatment is to remove it. It's nothing big and scary like the big scary cancer word. It's really and truly inflammation. And removing that source of inflammation helps with the process. So we take out any portions that are visually or palpably abnormal, and then we can either replace the implants or leave them out, whatever your preference is. And so that is the most common thing that I, as a surgeon, deal with as a complication from a breast implant. That risk is about 0.8%, but it can happen anytime for the entire life of the implant. As long as you have those babies in place, you can develop a capsular contracture. So I always say it could be 8 months after surgery or 18 years after surgery. It can happen either time. But you can change size at that point if you want. Now, speaking of the big bad C word, I always get asked, will my breast implants affect cancer detection? And the textbook answer is no, because mammograms have gotten really good. Usually what's required is an extra view or two to get around the concave shape. I always mess that up. The convex shape of the breast implant to see the entirety of your breast tissue. Now, mammograms have gotten really good, like I said. There can be a little bit of scar tissue around the implant, but that may just mean you need a faster, a smaller interval between your mammograms for a short period of time to ensure that that scar is not changing. And the reason that is because the way that fat and breast tissue heals or scars is it calcifies. And calcifications are what they're looking for on mammogram, ultrasound, MRI for cancer. The risk of mammograms being affected is higher actually with a breast lift or more dissection of the breast tissue. So the way I do my breast implants, I was going to say breast exams, don't need to go over that. Well, we can if you want, but breast implant surgery is I do my incision at the inframammary fold, and intuitively, there's no studies. What I mean by that is in my brain, it makes sense to do it that way because I feel like it's a cleaner location. It's more hidden than the armpit, than around the nipple, and it doesn't have as many risks as going in around the nipple, meaning nipple sensation, nipple necrosis, and then scarring. Hypertrophic and keloid scarring is more common around the nipple, and I feel like it's more visible, and it can distort the actual shape of your nipple if it's not closed correctly or if the stretch causes a problem. But also that dissection from the nipple dissects through more breast tissue, and especially periareolar and cancers in that nipple area are more common. And so for me, dissecting in that area only increases that risk that there could be issues differentiating between scar tissue and possible malignant or precancerous lesions. And so for those many reasons, I choose to do an inframammary fold incision. I also feel like it disrupts less breast tissue. It's easier to get into the correct pocket, either above or below the muscle. So for me, that's sort of the reason, one of the many reasons that I do my incision where I do. I also find that around the nipple incision, that dissection can thin out that tissue, and then you can have an area where you can feel the implant more. And in that region specifically is not the area you want to feel the implant or your partner. So boy, that took a turn from implants and bam, bam, bam to cancer. Wow. Sometimes my brain, it just goes weird places. But if you're looking out here, I'm in the back roads of beautiful Tennessee. This is like waterfall country down here. It's absolutely gorgeous. This drive during the fall, oh man, there's nothing prettier. But this drive during the winter, there's nothing scarier. So it's not bad right now, thankfully. But that's my drive for this morning. I'm just about to the surgery center to get started with our Bam 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 day. I should probably stop doing finger guns, but they're just so much fun. So don't report me. They're just fingers. They are deadly though, because they know how to wield knives. So thank you all for listening, for following along, and I'll do a more basic breast augmentation talk, like basically going through my consult later on. So I'll see you then. Stay tuned later. So again, thank you all for listening, and I will talk with you the next time I get in the car. Bye.